This is Jillian and James Tommel, and we want to talk to you about something that is currently happening in the United States today. We made this presentation discussing racial disparities in maternal morbidity and mortality in the U.S. to address a form of prejudice that can still be found in healthcare today. It would take such a long time to really dive into this subject, partly because in order to do that, you would need to define racism and prejudice and how they exist today in America in general before even really talking about within our healthcare system. So we decided to just scratch the surface and talk about the who, what, why, where, and how in regards to this topic.
Who does this affect? I thought the most effective way to address this would be to give some statistics. For example, black women are 3 to 4 times more likely to die from pregnancy-related causes than white, non-Hispanic women. Black and non-white women have almost 3 times the risk of death from hemorrhage than white women. Black infants die before 1 year of life at more than twice the rate of white women. The preterm birth rate for non-Hispanic black women is 1.6 times higher than the preterm birth rate for white women. And preterm birth-related infant mortality rates is 3 times higher in black women compared to white women. Preterm birth is the primary driver of the difference in infant mortality rate between non-Hispanic black and white infants, and it accounts for 54% of disparity. And finally, minority women experiencing higher lifetime exposure to chronic stressors, thereby increasing their risk for poor pregnancy outcomes. Of course, this is not only due to racism in our healthcare system, but it certainly is the driving factor.
What is happening? This is racism within the medical field that affects the antepartum, childbirth, and postpartum outcomes of minority women. In order to understand this, it is important to understand racism in our society a little better. There are really 3 facets of racism we want to address, though we have to oversimplify it a bit for time's sake. We want to talk about institutional, interpersonal, and internalized racism. Institutional racism is the different resources, services, education, employment, housing, healthcare resources and opportunities that are available to different races in our society. Interpersonal racism are prejudices and discrimination resulting in assumptions about capabilities and motives based on their race. And internalized racism is the acceptance and internalization of negative attributes, abilities, and really self-worth from within a marginalized group, limiting an individual's ability to reach their potential. So we really have it within the whole system, of America, in America, on a group level, and then finally on an individual level. So as you can see, it's definitely multifaceted. Some of the ways these affect minorities' health care is through a lack of access to quality health facilities and providers, and a highly concentrated food insecurity, leading to malnutrition and obesity that increase risk for complications for mother and baby. And another common complaint for minorities is feeling invisible or unheard when asking for help, or feeling pain or discomfort. And preterm birth is a significant contributor to racial disparities in infant mortalities.
Why does this happen? Consider some social determinants that affect bias in healthcare: education level, income, disabilities, immigration status, housing availability, access to quality healthcare, and allostatic load, which is the accumulation of stress over a woman's lifetime. And all the stressors are associated with worse health outcomes.
Okay, where does this happen? This happens really throughout the U.S., and some studies show that these disparities in healthcare are worse in places with a higher percentage of minorities.
When will it be fixed? When everyone has access to patient-centered care and access to quality health insurance. When healthcare improves its culturally sensitive model. When data collected for maternal and infant mortality is improved to look beyond genetic factors when policymakers screen for preterm births, which is the leading cause for infant mortality. For example, infections, diabetes, blood clotting disorders, prior preterm birth, stress, and smoking. And when providers are trained to address racism and build a workforce full of diversity.
And very similarly to that, how can we fix this? Of course, the solution is very complicated and unclear because really it involves shaking the foundation of our nation. But the first step is always trying to continue to bring awareness. And aside from that, a few ideas are going through health insurance and studying Medicaid expansion, having OBGYNs and medical professionals with demographic similarities to their patients, improving patient-centered and culturally sensitive care, addressing and diminishing maternity care deserts, in which access to maternity is very limited, and it typically occurs in counties with a higher rate of poverty. Expanding access to midwives and doulas, which studies have shown can lower hospital bills for insurance companies and patients. Only allowing medically necessary C-sections. There are many risks associated with C-sections that are not worth it if it's not necessary. Continue to educate health, literacy, and childbirth education for self-confidence and self-efficacy. Maybe even using incentive programs within that. Development and testing of interventions, addressing racial discrimination. This one's really huge. It's a hard thing to test because there's so many moving factors. So many have given up trying, but it's crucial to future research and implementation of problem solving and evidence-based practice. So we really hope that you guys have enjoyed our presentation and have learned a little something. And that's it.
Thanks, guys.